Hello everyone, this is BrainlessMedico and I am Dr. Manoj, and today we are going to crack one more important topic under respiratory medicine, that is your pulmonary hypertension. So in this video we are going to do a clinical and hemodynamic framework for classification, risk factor, stratification and targeted therapy required. So it's a clinical review. So let's see how we are going to proceed in a nutshell. First we have to see the triggers, then we have to see how we are going to screen the disease, then we have to gold standardly diagnose the condition so that we can treat the patient in an appropriate way. So let's say the most common symptom when a patient comes to the casualty, the patient never comes to OPD with this condition. He usually comes to the casualty with a unexplained shortness of breath. So there are many DDs for the shortness of breath. No need to worry, you can go and watch my shorts which where I gave the details about the unexplained shortness of breath DDs, and then we screen with the ECG usually to detect the pulmonary pressures non-invasively. So ECG is a non-invasive method. So and gold standard, it's always it will be the invasive method. So it will be your right heart catheterization. So we will measure the mean pulmonary arterial pressure. So MPAP, usually the magic number will be 20. So you have to remember this 20 when it comes to the pulmonary hypertension. So it's a classification based on mechanism, okay? Based on mechanism. So we have 5 groups. Remember, this is not in a use for a treatment, but you have to remember for a MCQ purpose. So we have group 1, group 2, group 3, group 4, group 5. So let's see how in further pulmonary hypertension we have the clinical classification, where we'll divide it in another way for the easy purpose to treat the patient on a casualty purpose. So this is a theoretical part, just remember this part. So in group 1 we have direct blood vessel involvement. Here what will happen is there will be genetic mutation of BMP-R2. Okay, this gene will be mutated. No need to dig into the what it causes and all. No need to dig. Just remember BMP-R2. Then we have connective tissue disorders which such as scleroderma, rheumatoid arthritis, SLE. And coming to drugs, toxins such as fenfluramine. You can remember. Otherwise, just remember drugs or some toxins, and idiopathic. Then we have in group 2 we have left heart diseases. It is the most common group caused by left heart failure leading to vascular back pressure. If let's see in a simple nutshell, this is the right heart and this is the left heart, and it will be connected to your lung. So if this is not working, the pressure will load into the lung part and this will come to the right part. So this is what happens when increase in the pulmonary hypertension. So here we have in group 2 we have left part. Then coming to the group 3, it will be related to your lung. So respiratory causes, this is the second most common mechanism, will be hypoxemia, persistent pulmonary vasoconstriction, and COPD is the main culprit in a respiratory system, and another diseases like ILD and your bronchiectasis. Then we have obstruction, where chronic thromboembolic pulmonary hypertension will be seen. Just remember CT-EPH. Then group 5, it's a miscellaneous. Usually we keep where the cause is unknown or multifactorial. Just remember, like group 1 and group 4 are together working, so we can keep it as a miscellaneous, just like an example. Otherwise you can say like any other diseases like sarcoidosis or even sickle cell disease. So just remember, you have to remember mainly group 2 important. Group 2, the other thing will stand in another group, we'll see in a further. So let's take group 1 is a BMP-R2 gene mutation. There will be restricted volume. I think this is more than sufficient for this BMP-R2 gene mutation. Okay, no need to dig. There will be restricted lumen, so which leads to the increase in the pulmonary hypertension. Then coming to the hemodynamic consequences, there will be direct involvement of pulmonary artery leads to massive resistance against the right ventricle. So where it will give PVR will be more than 2 Wood units, where PVR, not movie, it's a pulmonary vascular resistance. If a blood is moving like this, it has to be given some resistance opposite to that blood flow. We call, since this happens in a pulmonary vessel, so we call it as pulmonary vascular resistance. You have to remember one more magic number, it's more than 2 Wood units. So one magic number was more than 20 MPAP. Then another magic number is your more than 2 Wood units, which is PVR. I hope it's clear till this. Then if there is any doubt with the group 1 and group 2, you have to go back and just clear it off, because further video will be confusing if you don't understand what actually group 1, 2, 3, 4, 5 stands for. So let's clear off the further video. Hemodynamically classification, we consider it as a pre and post capillary. So in lungs, when it connects to pulmonary vessels, inside we have some capillaries, right? So we have pulmonary artery and pulmonary vein. This is a lung which is connected to the pulmonary artery and vein, and there will be capillaries inside the lung which actually plays role in pulmonary hypertension. So we call it as pre and post just remember your group 2 is a post. Other all are included in a pre except fifth. Okay, just remember 2 is a post capillary cardiac passive. So group 2 is a origin actually. So what we learnt in a group 2, it was all about left heart diseases, forces back pressure through the veins. Whereas in group 1, 3 and 4 origin, resistance build up here before the capillaries. Then coming to the basic differences, you need to remember when you are studying some hypertension, there should be some magic numbers and some values you have to remember so that you stand out from the regular people. So let's see how much what extent you people can have a number value memory. So it's a pre-capillary and post-capillary. This is group. Again and again I'm stressing just because when examiner asks you which group, sometimes they may give you the group or they may directly say it's a pre or a post capillary pulmonary hypertension. So let's say once again it's 1, 3 and 4. 5 is not included in pre capillary and group 2 is completely post capillary. So here are some magic numbers. The MPAP will be same just because it's a magic number I said, and PVR again we have 2 value. It is more than 2 value in pre and less than 2 value is in post. Then we have wedge pressure, no need to dig. It's called we can call it as capillary wedge pressure. Important topic, you need to remember 15. It is the only one value which will be less in pre-capillary, which will be we can say it's more in the post-capillary. Yeah. So what are the magic numbers you need to remember? Here is 20, 15, 2. MPAP, wedge pressure, PVR. And the only one which is more less in pre-capillary is your PCWP, that is less than 15. I hope this is clear. If there is any doubt, kindly go back and watch the magic numbers. This play an important role in the treatment part. So you just have to by heart this. Then the diagnostic anomaly combined with pre and post capillary pulmonary hypertension. Usually what happens occurs when treating left heart disease fails to improve pulmonary hypertension. So PVR remains more than 2 Wood units due to long-term vascular remodeling. Then we have clinical decision. Treatment, the important part is one part you have to know the proper symptoms, signs. Then the second part you have to diagnose and confirm, and the third part, actual part, what patient is expecting from a doctor is a treatment. So when you don't know the actual diagnosis, then you can't treat. If you study so many drugs and all, if you don't know how to diagnose, it is waste. So be a clinical doctor, study plenty of books how much you want, but be practical. What is important for the exam and what helps in a patient treatment, you have to remember that. So let's continue more of a theory part now. Yeah, there are so many things you need to learn in this, but actually practically there is very less part you people will learn when you go for a actual setting. So then we have treatment pathways for pulmonary hypertension, which is again a important 3 marker. So pulmonary hypertension, you have diagnosed with such a great knowledge of having all the symptoms, classification, everything. At last you diagnosed it as a pulmonary hypertension. Then what we have to do being a doctor? So we have to divide the patient condition into the majority and the minority. So group 2 and 3 are considered under majority. So treat the underlying cause. It may reduce the patient dreadness, or what we can say is like it will be automatically corrected probably. If not, we can go with proceed with the minority treatment even in a majority. So in minority, we have to specifically treat the disease where group 1 outstands from the other thing. So let's see, let's take an example. In group 2, we have left heart failure. So it is the main culprit. So if you treat left heart failure, the pressure reduces, and what do you say, MPAP, CWAP, and one more is your, what do you say, PVR. These three will be automatically corrected. So no need to worry. But you have to worry when it comes to your group 1. So there we have to go with the pharmacological therapy. Requires advanced hemodynamic and risk stratification and to determine the actual needed drugs. So let's see how we can proceed with the treatment. So we have to do a clinical decision where vasoreactive testing has to be done. So first, to treat the patient, you have to confirm the diagnosis. You have classified him and the patient was in minority, which is group 1. So you have to confirm the diagnosis. So you have to go with the right heart catheterization just to diagnose the patient. Since the minority is the case, there is no patient is not going to, you are not going to lose the patient. So you actually get some plenty of time to actually diagnose what is the cause. So we are doing the right heart catheterization. So we will do with the vasoreactivity testing. So if yes or no, it is just yes or no. If yes, so reduction of MPAP will be more than 10 mmHg. So we have to administer the calcium channel blockers. We'll be discussing what all the drugs actually required in treatment of this pulmonary hypertension in a further thing. So then if there is no, CCB you are going to give and he will be perfectly fine. If no, then you have to go with the further treatment where we will see no significant pressure drop. A single term I am using in this flow chart, it is very important. You have to focus everything. If you are taking a note, no need to worry. I will be providing this PPT presentation to you people under the video. You can just go and download, save your time, just by heart everything and do well in your exam, so that you'll be getting your dream choices and you'll be treating patients in a better way. Then proceed to advanced risk stratification. So we have treatment tiers: non-risk, non-high risk, then we have high risk. So we have to prescribe. So before going to the risk thing, we have to know NYHA classification. It's a NYHA assessment tool where we have 4 classes: 1, 2, 3, 4. So it's all about shortness of breath. SOB is means shortness of breath. Okay, shortness of breath on exertion, on ordinary activity. Then we have shortness of breath on less than ordinary activity at rest. So just remember, you are working out, so you are in class 1. If you are working out, then you are getting a shortness of breath, it's right, absolutely normal, it's fine. Then a normal activity, if you are walking, still you are getting shortness of breath, it's not okay, but still people can get it. Class 3, shortness of breath on less than ordinary activity. If you say like you walk 1 kilometer or some 500 meters, sorry, not kilometers, you can't do it, some 500 meters, if you are getting If you used to get some exertion, then it's totally fine. But if you're getting that on walking for 100 meter itself, then it is class 3. If you are still sitting and still getting the shortness of breath, then it is highly abnormal. You have to go for the treatment. So let's see what is the purpose of learning this NYHA classification in the treatment section. So we will divide the patient into non-high risk and we have high risk. So if 1, 2, 3, so these 3 goes into non-high risk. Since these things happens with even what you say normal patients, so we consider them as a non-high risk. But when it comes to fourth one, when you are sleeping, you won't get shortness of breath, right? There has to be some abnormality. You are getting shortness of breath even at a rest, so it is compulsory, it has to be high risk. So let's say it's high risk, so how you are going to manage? If it is a non-high risk, you have to go with the ERAs and PDE5 inhibitors. So, and in coming to high risk, you have to add IV ipoprostenol. So let's see pharmacological target map. So what all drugs actually we need to learn under this topic? See, studying hundreds of drugs doesn't fetch you anything. It is not necessary to learn every single drug present in a KD Tripathi or Goldman, something like that. So you have to learn what all is recent update and what is the necessary drug you need to know under the actual topic. So let's see. If calcium channel blockers, we said when we are treating group 2 and 3, we will be going with the nifedipine. It's a calcium channel blocker. Don't say you don't know, because since you are seeing this medicine video, the person who is actually seeing this medicine video, you have to be well versed with the nifedipine. If you want, I'll be checking out of these what you said drugs related to all the respiratory medicine under a separate video, so that we'll be doing a quick revision for all the treatment before your exams. So I'll be promising you people, so that you don't miss out any single one answer. Then coming to second one, endothelin receptor antagonist, ERAs, which you are going to give in a non-high risk and even in a high risk patients. So that is bosentan. This is an important drug, you need to remember. I don't know, ambrisentan you will remember, but you have to remember bosentan. If possible, you can remember both of them. If at least you have to write in MCQs, they'll give bosentan as a common thing. If fine, it's fine. It's a sentan. You can remember ambri and bo. Okay. Then coming to PDE5 inhibitors, I think you people are well versed with this, sildenafil and tadalafil. Then we have prostacyclins. So it will be inhaled iloprost. Then we have, as I said, this I'll give in a high risk patients. IV ipoprostenol. It's a prostenol. Prostacyclin, prostenol. Okay. Prostacyclin, we have targeted therapy, Selexipag. Okay. One homework for you people. It acts, what do you say? It acts on a particular receptor. Tell me that what particular receptor it actually acts. Okay, Selexipag, it's a homework. Then we have guanylate cyclase stimulator. In that we have riociguat. This is okay with if you don't remember in your theory paper, but you have to remember this in your MCQs, because these 3 are okay questions. These 3, if you remember, it's fine, okay. But if you remember these 3, you are the game changer. So be a game changer, turn from there to here. So let's say riociguat, by heart it or do something, paste it on a wall, take one screenshot of this page and paste it on your wall, so that you don't forget the pulmonary hypertension topic. I'm sure you will get one or the other question under medicine. This topic is so super duper important. You have to study in a detailed way, and don't go for running around the many books. I think this PPT is sufficient for the more marks and even more knowledge. Then coming to the let's take some cases. Young female, yeah. When you are sitting in a casualty and you get a young female, guys, you have to take some notes. You have to go there, and ask them what is the problem. Be a man, go and ask what is the problem to the young female. So there is a unexplained shortness of breath, then though she needs some attention from you, so she has some shortness of breath. No evidence of left heart disease, so since no one is there in the heart, so there is no left heart disease, lung disease, connective tissue disorder, drug or genetics or etiology. And when you know this, like there is no other problem with her, and there is a shortness of breath, guys, since you took the notes, you have to proceed. You can't just stand and wait, let's see what happens to the young female. And if the patient is male, girls, take some notes, go and ask what is the problem, be gentle with them. Okay, echo, elevated pulmonary artery pressures, then there is RHC, right heart catheterization. Don't forget, you have to do right heart catheterization. There is a magic number which I told you again and again, that is more than 20. So we have diagnosed it as a pulmonary hypertension. So let's say vasoreactivity is positive and it's a green signal. Since I gave it as a green signal, girls and boys, you have to go with the treatment to impress that guy, not in the way of other way as a doctor to the patient. Okay, let's take it as a idiopathic pulmonary hypertension. It's a group 1, so you have to proceed with there is only one treatment you have to proceed, that is your CCBs. Then let's come to clinical case 2. Since I am a male, so I just put the question into the female. So if a listener is a female, then let's consider it as a male. Then 28 year, whichever gender you want, you can take it. Clinical status grade 2. Can I know what is the actual grade 2 stands for NYHA classification? It's a grade 2. Then idiopathic pulmonary arterial hypertension is already you are suspecting, so you underwent the patient into the vasoreactive test and it's negative. It's a red flag, don't go further, because she is vasoreactive negative and NYHA 2, which stands in the non high risk. She requires ER and PDE5. Let your seniors come and advise the drugs. No need to proceed. Since it is a red flag, you have to just say that my senior is coming, I know the treatment, but let my senior to handle the case, so that they'll come. Since you people being a 4th year or an intern, you don't know actually what dose you have to proceed, so it's a red flag. Never ever give something which is not in your hand. Just ask your seniors to give the drug. Initial treatment includes ambrisentan or your bosentan, who are your endothelial receptor antagonist, and we have to add some other drugs if the patient is not getting the benefit of the actual drug. So can I know what is the grade 2 stands for NYHA in the comment section? Okay, I know that it's on an ordinary activity, you will be having the shortness of breath, but you have to type it. Since I taught you this much, so you have to at least answer the question so that you won't forget what is grade 1, 2, 3 and 4. This is an important Viva question. They'll be asking, it is even in a cardiovascular system and even in a respiratory system. So this was all about your pulmonary hypertension. A very important 10 marker, a 5 marker and important 3 marker, and if multiple questions has been come from this topic in your MCQs, maybe INICT and even NEET and your FMG and other plenty of exams which you people are undergoing to write. So let's finish the topic now and revise it quickly whenever there is an exam. Okay, I'll be providing this PPT. You can just go and download it from the under description part in the video. So thank you and don't forget to subscribe.